Hello, everyone. I'm Dr. Diana Bitner of True Women's Health, and I am an OBGYN by training, but am very interested in women's heart disease. So tonight we're here to talk about our Let's Chat, Take Prevention to Heart. And I've asked my partner, Dr. Celia Egan, to join me tonight because she is an internist, board certified in internal medicine, board certified in obesity medicine, and together we want to have a conversation about heart disease and why we care and why we're glad that you're listening. So Celia, so glad that you could join.
Hi, Dr. B.
Hello. We worked together all day today, so it's fun to come together at night and have a chat.
Yeah, it is nice to take a deep breath in, right? Because we work so hard trying to see as many patients as possible to pause and talk about preventative health.
Exactly. So I care about this because, like my book says, I want to age like that. And for so many of us, heart disease would just get in the way. It would shorten our life and we would probably not get to age like that. So I care about this because I want women to know what they can do to age like they want. Why do you care about this?
Yeah. I care about this because I think shockingly, it's something that's happening to women at a younger and younger age. And, as a doctor in preventative care, which is what I mostly do, I don't like surprises, right? I don't want to get that phone call of one of my patients had a heart attack or a stroke and we didn't know, right? We didn't really review that. So I care because every person that walks into my office, I really want to take a serious look at their vascular risk. And that's the risk of having a heart attack and stroke, and sort of making sure that they understand sort of the causes behind why we develop vascular disease and what we can do to prevent it.
Sure. Well, I think about things like a gallstone or an infection or a broken arm, right? It's a problem.
Right.
We can identify it. It's not going to kill you. We can fix it and you go on with your life.
Yeah.
Heart disease is one of those things, right, that develops silently over time.
Mm-hmm.
And, we like to say it's silent until it's not.
Right. Absolutely. Yeah.
So it just like you, it would just kill me if someone has a heart attack and like, why didn't I know? Why did this happen to me?
Yeah. And I think that I think another real sticker is that there's a lot of preventable risk factors, right? There's a lot we can do in terms of our lifestyle and medications to sort of prevent some of the vascular changes that we see.
Right. And two, again, it's a silent condition and it's so easy to say, oh, I'll deal with it later. I'll worry about it later.
Yeah.
But, unfortunately, when it's developed, it's really hard to reverse the effects of this. And so, the other thing is we've got to attach it to something we care about. So I want to talk about Sarah. Sarah is a patient that I saw. Of course, it's not her real name. And she came into the clinic because of hot flashes. Sarah was having terrible hot flashes and night sweats. She wasn't sleeping well. She didn't feel real sharp in meetings. She was feeling like she wasn't keeping up with her colleagues at work. And she was really frustrated. She said, can you just help me with these hot flashes? And also weight gain was an issue. She, got through COVID, working at home, but now she's got to put her suits back on to go into the office and they don't fit anymore. Mm-hmm. So she was really discouraged. Mm-hmm. And like Dr. Egan and I do, when patients come into the office, we, go through the main thing that they want to solve, what made them call True and what made them come in. And then the next step is to say, what do you want? What do you want as you age? What is your picture of self? And Sarah got a little teary and she said, I have to tell you, I saw my mom go through perimenopause, menopause. She said I didn't have a name for it at the time, but I saw her she gained weight, she got tired, she didn't participate in events as much. We used to go on these walks and then she was too tired, she didn't want to go anymore. She talked about hot flashes and then she had a heart attack. Like she died at 56 of a heart attack. And I don't want that to happen to me and I don't want to do that to my kids.
Yeah. I mean, at 56, there's really a lot more life to live, right?
Right. And so because her mom went through this, there certainly is a chance that this could have happened to Sarah. So the first thing I want to talk about, and we'll keep coming back to Sarah, is what is cardiovascular disease?
Yeah. I think we have some pictures to kind of have a bit of understanding. Yeah. So go ahead, Dr. B.
Well, I was going to say, Dr. E, you and I kind of think of this a little different. I think we just have different words to describe the same, but I love how you talk about that this isn't a blood disease per se, it's a tissue disease.
Yeah. When we think about our heart, I like to think about it like a house. The walls of the house are what make up the chambers that cause the squeezing function to move blood in and out. And our coronary arteries are the plumbing, right? They're there to supply the blood to those walls so that we can keep a very strong muscle free that can just keep that squeezing and relaxing function possible.
Yeah, and so when those vessels get clogged, then we can't get blood to the heart, and those heart muscles can't function as well. It's the same thing for the blood vessels in the brain, that
Absolutely.
when the vessels get clogged, it can cause stroke, but even more so when the little blood vessels get clogged way up in the recesses of the brain, it can cause dementia. So the biggest risk factors for dementia are the same risk factors for heart disease.
Yep.
And I also think right about vascular disease in the kidney. So you can speak more to this, of course, than me, but I think about when we start to get maybe vessel disease in the kidney, we start to see hypertension or high blood pressure. Yes.
Yeah.
So
Yeah, and even though our kidney function maybe isn't declining enough to see it on labs, or we don't notice it like in our urinary frequency, it still could be happening, causing our blood pressure to slowly kind of creep up.
sure. So when we think about this, I think about this in terms of how the blood vessel walls can get sticky. And so, you can have cholesterol in your blood. We all have some, of course. But if the walls are sticky, then even a small level of cholesterol could stick to the wall, right? And start maybe a plaque developing.
Yeah, so how I like to think about it too, and I think that a sticky is a perfect analogy. I think about in my head, I try to separate out for people, that this is a tissue disease. There's a problem with a part of our body, similarly to like the inside of our mouth that we would talk about. And there's an inflammatory process or something that is erupting or growing sort of in that lining of our blood vessels, again, similar to the lining of our mouth. And we, a lot of the times, look for things that are going on in the blood to kind of further risk stratify how bad the tissue disease is. And I think we'll circle back around to that analogy when we talk about what to do about, further risk stratifying and screening for vascular disease. But I think that sometimes can be helpful to kind of as a reminder of, yes, this is a tissue disease. And when we're talking about cholesterol levels or lipoprotein changes, high blood sugars, high blood pressures, that we're trying to understand what's going on in the blood that's causing all these problems in the tissue.
Exactly. And so, here we're both wearing red tonight. This is Go Red Month. This is why we're talking about heart disease. I want to talk just a minute about why is this a big deal? So I know we have a statistic about this that I think is really significant in that it's coming. There we go. That heart disease is the leading cause of death among women in the US, more than all the cancers combined.
I mean, isn't that kind of astonishing?
It's astonishing.
When you think
I'm glad there's
yeah.
so much conversation about breast cancer risk reduction and early diagnosis. So critical, so important. But when heart disease actually kills more women than breast cancer, we need it also to get lots of attention.
Yeah. Yeah. I think a lot of the times when people think about heart disease, they think about it as something that would never happen to them, right? It's like, well, I don't have this risk factor. Oh, maybe it's not that bad, right? And so it just seems so far away from us a lot of the times, unless we have kind of a strong family history. But 1 in 3 women will die of a heart disease. I mean, that's a scary stat.
And it's preventable in 90% of the cases, or most cases. This is preventable. So I hope when I go someday, it's on a beach of natural causes when I'm 110. I don't know. But I just don't. I want to be able to go skiing and not worry I'm going to have a heart attack. So again,
you're going to want to die at 110 at your true office.
That's right. Well, maybe so. Yeah. But, I think about the history of this. So circling back to Sarah, back when her mom was having her progressive fatigue, her progressive shortness of breath, she couldn't go on walks that were as long. She was getting tired. She was sweating. And so, back at that time, people didn't know enough about heart disease. It was often thought to be just a disease of men. And, it wasn't until a couple, actually female cardiologists, really started looking at all the women who were dying of a heart attack who maybe had been turned away from the ER because their initial stress test was negative, or their symptoms progressed and they were told they were just nervous or anxious, and so they didn't go back to the ER.
Yeah.
It's not that doctors didn't care, they just didn't know.
Yeah. You know, when I was like doing my internal medicine training, we talked a lot about chest pain, and it really got a lot of buzz, right? You say you have chest pain, you go to the emergency department, and a lot of things happen. But, you know, a lot of the times when women are talking about their symptoms of cardiovascular disease, it's what we call atypical chest pain, right? A little bit of fatigue, sometimes some nausea, a lot of anxiety, sort of a sense of doom. And it's not just this typical textbook chest pain that we see a lot of the times when we see in cardiovascular disease in men. So,
can we rename this? Like, the chest pain
right.
is typical in men.
Right.
The fatigue, shortness of breath, vague arm check, that's typical for women, right?
Yeah.
So I think we should say that. And I would love to show the picture now of how heart disease often develops differently in men than women. When I went to my first meeting on women's health back in 2003, I'll never forget, Dr. Noelle Berry-Mers was there. And Dr. Berry-Mers is a cardiologist. She now runs the Barbra Streisand Heart Center in California. And she was there talking about how she was a fellow in the ER in Pittsburgh. And she saw so many women come in with chest pain, and then they would be evaluated with an EKG and a blood test, and they weren't having an actual heart attack at the time. They had a stress test maybe that was even positive that showed that when they exercised, their EKG, their rhythm changed, not their rhythm, but the electrical currents.
There was electrocardiogram changes in response to activity.
Yes.
Yeah.
But then they would have, let's say, a cath. They would have the test where the dye is shot through the blood vessels, and it was negative. It looked okay. And the women were sent home, and they would die of a heart attack. So what the heck? So she started this whole group of studies called the WISE studies. So it's so important that if you see a cardiologist and you're a woman, make sure that they know the WISE studies. So Celia, if you'd like to talk about this, I love this picture.
Yeah, I really think that it speaks so, I mean, you know, a picture's worth 1,000 words, right? So if you look at the top, this is sort of how we see vascular disease present in men, which is this lesion in the big, long blood vessel tube that sort of slowly closes down over time. And what happens is that vessel can initially clot off, and that's where we get clutching chest pain and all the male typical chest pain symptoms. And this is why on a cardiac cath, when they shoot the dye, what they're looking at is only what's in that tube itself. So you can clearly see that there's a big fat open tube, a small narrowing, and then a wide open tube afterwards. And so it's very clear that there's a plaque buildup there. Now, if we go to the lower, artery that's there, this is how arteriosclerosis or vascular disease sort of develops in women. It's a smaller, non-focal narrowing all over the entire pipe. So you can see that when they do the cardiac caths, the dye stays in the piping, but it all looks pretty even. That's because the disease is everywhere and kind of uniform. So it doesn't look like one clear lesion, and why a cardiologist would miss that during a cardiac cath.
Right. And they even call this cath negative heart disease.
Yep.
And I love the analogy that Dr. Berry-Mers said. She would say, with guys, they leave their socks in the hallway. Whereas women, they hide their socks in the closet. So, we're developing heart disease by that plaque going through the wall and then living in the wall, whereas the guys, they store it right in the channel. So again, just so important to notice. So again, with men, of course, they're going to have that crushing chest pain. Some of their heart muscle is dying or struggling to breathe. Whereas with women, it's a slowly developing. And she would talk about how the blood vessels, when we exercise, so let's say you run up the stairs and, whether or not you're out of shape, but you can run up the stairs and you recover really quick and no big deal. But what happens is that when we run up the stairs, our blood vessels dilate to bring more blood to the heart and more blood to our muscles. These vessels with atherosclerosis all along the edge, they can't dilate. They can't open to let more blood come in. And that's why I've been taught tell me what you think, but that women develop this progressive shortness of breath, this progressive exercise intolerance.
Yeah, I think that's very well put. And I think over time they just aren't, obviously, as you can see, the whole tube is sort of changing. So there's no actually healthy tissue anywhere, right? And so that's why it's really hard for the heart muscle to sort of get any blood. And then it just sends the feedback to the rest of the body that we can't do this, right? We can't carry our groceries. We can't walk up the steps. I just want to pause because Vicky asked a question. Does this affect the circulation down to your feet? I think what you're maybe talking about specifically is peripheral artery disease, which is very similar vascular disease that develops in the big blood vessels that supply the tissue to our muscles in our legs and down to our feet. Yes, we can see this. It's much more common in people who are tobacco users, but it's a very similar sort of process.
Yes. And I guess we always want to throw sexual health in here a little bit, but I had a patient who could no longer have an orgasm. And one of the reasons was that she had such bad peripheral disease that her blood vessels down there were blocked. And that's what prohibited her from having normal sensation. So,
How frustrating.
Yeah. So at least it led us to diagnose her heart disease and we got her on a good path, but it was an unfortunate evidence of this. So again, to come back to Sarah, so now we're talking about this with Sarah, in that, yes, her mom had probably gradual gender specific or developed heart disease like we're talking about that women do, and how Sarah doesn't want this to happen. And so, as I was talking to Sarah, then we started to talk about potential risk factors. So number one, her mom had a heart attack less than 60. So that's definitely a red flag. Number two, I asked Sarah about her history. She had diabetes when she was pregnant. And so when a woman has diabetes in pregnancy, she has a much higher risk of having glucose intolerance or insulin resistance, prediabetes, diabetes, as it would progress as she gets older.
I just want to pause for a second. I think it's really important because until I really started working within the menopause world and working with you, I wouldn't have paid as much close attention to the things that happen during pregnancy. I sort of would kind of touch on it briefly, but definitely not taking as much time as we do now, trying to tease out exactly other medical things that happen during women's pregnancy. And I think that it's a huge risk factor that is very much overlooked.
It is. And think of pregnancy as the biggest stress test you can have, right?
Yeah.
So not only are we stressing out our glucose tolerance, but if for women, for example, who have severe preeclampsia, especially if they have high blood pressure, they develop HELLP syndrome with low platelets, that's an endothelial disease. The endothelium is the lining of your blood vessels. And we know that severe preeclampsia is a disease of the blood vessel lining, of the placenta, of mom, lots of factors involved.
Mm-hmm.
But if a woman has severe preeclampsia, she's at very high risk of developing this microvascular heart disease in menopause and beyond. So super critical. And so, in talking with Sarah, she had some of these risk factors, and she, again, could just see her stages mirroring what her mom went through. And so that made her really concerned that she would also develop these issues. And so when we talk about, I'm looking at my notes, I don't want to forget anything, but we talk about then what other risk factors. So Celia, when you see someone, what other risk factors do you think about?
We definitely think about family history. I think I definitely look to someone's what we call glucose tolerance, right? That's their ability to handle sugars. Where are they in this spectrum? Meaning, do they have really high blood sugars to start with, medium high blood sugars, or really high insulin levels that they're secreting in order to maintain a normal blood sugar, and everywhere in between. So I really care a lot about people's blood sugars and where they are in that system. I really care a lot about people's blood pressure, not only in the office at that moment, but kind of where it goes throughout time and where it has been, if it's slowly creeped up over time. I care a lot about where people's lipoprotein levels are and other sort of factors that we would sort of call cholesterol and how involved those numbers are. And I care about if they're sleeping and their stress levels, right? I think we know that people who are uber stressed for a variety of different reasons tend to have higher rates of cardiovascular disease, even if some of those other things seem normal.
Right. And even mood disturbance. We know that women who have depression have a higher rate of heart disease. Women who have heart disease have a higher rate of depression. So we never want to blow off a mood disorder and say, here's some, medication, see in a year. It's really then looking for those other factors. So, at True, we have our app and our intake forms that really allow us to ask a lot of in-depth questions. So again, I love how when a woman comes into True, we already know her so well that we can get right down to business. And so Sarah's question is, okay, I haven't had a period in 2 years. What does menopause even have to do with this? And I always think about this like the perfect storm. So of perimenopause and menopause, we have one storm front and another storm front coming together. And one storm front are all the symptoms that go along with menopause. So hot flashes, night sweats, not sleeping well. So think about if you have night sweats and you went to bed at 11, you woke up at 2, at 3, at 4, at 5, the alarm goes off at 5:30. Do you think you're going to get up on the treadmill? Probably not.
Yeah.
You might then during the day not feel as good. Maybe you're a little bit more, have more anxiety, mood disorders. So you just don't feel like doing stuff you normally like to do.
And not only that, but I think we've seen a lot of the times when, maybe we're not sleeping and it creates this perfect storm of now we're leaning a little bit, our ability to make a good food choice really goes down, right? Our hunger goes up, our cravings for sugar and fat, alcohol, all those kind of things that we know aren't on our healthy eating plan go up. And so it just further creates that perfect storm.
Totally agree. And then the other storm front is the changes that happen with menopause. So as our estrogen goes down, our insulin resistance goes up. And, that's one factor. I think it's really interesting. Again, you and I talk about how the worlds of obesity medicine, internal medicine, and menopause have never really mixed a whole lot before. And as you and I work together, we're learning so much from each other. So how else do you think about menopause and heart disease?
I make a joke that, I think I think insulin and estrogen are just working so hand in hand together, basically to signal to the rest of the body, like what the hell's going on, right? Like who needs energy? What are we doing? What's going on between our brain, our heart muscles, our skeletal muscles, our liver, our ovaries? And so when we see this huge change of our estrogen level, I think there's honestly switches in our liver that get flipped that our body's just unable to process some of our normal sugar and insulin levels like we were before. And that can lead to inflammation and other downstream effects that we see.
Right. And so with that, of course, can come that central weight gain. So we jokingly call it the menopause, where women start to gain weight around their belly. And of course, you and I talk about this a lot, but it can be a sign that insulin resistance is on the rise and just increases that cycle. And especially if women start to gain more weight and then heaven forbid they get sleep apnea. They're not sleeping well. They're not getting oxygen to their brain and to their heart, during the night while they sleep. So again, it can be this vicious cycle that we want to stop.
Yeah.
So I think about, okay, now we've got Sarah in front of me and she said, help this not happen to me. So before a patient even comes into True, we'll often draw blood work. Sometimes we draw more afterwards, or we might talk first, but we like to get some blood work to get a baseline understanding of what's going on in the blood that can affect the tissue. So for sure, we get a basic lipid profile. We get a complete metabolic profile that looks at fasting blood sugar, of course, kidney function, liver function. We get something called a CRP that is one measure of inflammation, and the A1C, which is a measure of blood sugar over 3 months. Celia, how do you think about, using this to stratify? We talk about scores that we might calculate.
Yeah. So again, if I think back to what am I looking for? I'm looking for a tissue disease, right? And so I'm looking at the CRP, that inflammatory marker, to say, is this a marker that there's some ongoing tissue disease? That's how I think about it. And then I look at the sugars and our lipid levels as one way of measuring if our body's handling kind of our energy loads as we're eating, right? Is our liver making the best choices, right? If our triglycerides are sky high through the roof, then I know that there's some sort of misfire there at our liver of our ability to handle fats and sugars.
So yeah, and I love how then we think about, for example, one score we can use is the Reynolds score. So the Reynolds score is a gender-specific risk score for heart disease. So it takes into account family history and it takes into account the CRP. And so I definitely see correlations, this and the ASCVD. So the ASCVD, as I understand, was developed in men and women, but it looks at just, again, the basic factors and gives us a percentage of risk of a heart attack in the next. The Reynolds is 10 years. I don't remember, sorry, what the ASCVD
also
is.
10 years as well.
Also 10
Yeah.
years.
Yeah.
And so it just gives us a sense, and then what we do next.
I think one of the most frustrating things about these risk factors is you kind of hear sometimes the extremes, in a sense that, I always say not every person with high cholesterol has a heart attack, and not every person who had a heart attack has high cholesterol. So we sort of need some of these calculators that have been used at looking at many studies, meta-analysis, to sort of pull together some of this information to better understand where that person is in that moment in terms of their cardiovascular risk, because it can be very frustrating to feel like you have this one thing but not another thing, and to get a fair sense of what's going on, since we look at so many different factors.
Sure. And then I think about, okay, first of all, when a woman is starting to be evaluated for these things, it's always then talking about what are the danger signs. So before we know more information, if you have what symptoms. So Celia, when would you tell someone to call 911, for example?
So, I think definitely if someone's having that chest pain, because it's not impossible to have that in women, right? It still happens, and people can get that sort of crushing chest pain. Another thing can happen is that you get short of breath quite quickly, right? Where your short of breath is, and I feel like with COVID, we've talked so much about being short of breath, but really, like, you can't walk to the bathroom, right? Like, you're normally exercising, no issues, and then all of a sudden, like, I can't walk to the bathroom. That's being short of breath. And so that would also be another sort of danger signs that you need to call sort of 911 right away. And honestly, sometimes it's trusting your gut, right? If you've been slowly not feeling well, and you're just like, I feel terrible. I have this sense of doom. I feel panicky. I'm nauseous, right? I mean, it's sort of a low threshold to call go to the emergency room or be checked out.
Yeah. And so I just hate how women just put everyone else first. And the joke is that if a guy has chest pain, he's like, stop the world. I need to get checked out, which is awesome, right? But women are like, yeah, I'm going to make sure everybody else is good. I'm going to feed the cat. I'm going to feed the dog. I'm going to clean the kitchen because, I don't want to leave the house messy. And then she drives herself to the ER. So, it's just so important. Women, you matter. You deserve to get checked out. Like, don't blow things off because you might not think they're so dramatic. Like, trust yourself.
Yeah, I think that's really important. And listening to your gut of being like, things just are not right, and that's okay, right? And it's okay to go to the emergency room and be wrong. Oh, maybe maybe you're not having a heart attack. That's okay, right? And we'll deal with whatever comes after that. But I think trusting your gut and sort of being open-minded to getting checked out, first thing.
Yep. And so many more emergency doctors are trained in women's heart disease. So I'm just really encouraged that more and more, a lot of ERs have women's chest pain centers. They're just much more aware that the symptoms in women are going to be different. And so again, it's, all of you, like, we as women, we need to be bossy. We need to say what's going on. We need to really make sure we're getting good evaluation, but also it's encouraging that physicians are better and better trained. So that's encouraging.
And of course, we're talking mostly about the vascular disease that's affecting our heart. But, of course, the vascular disease that's affecting our brain, anytime you have speech changes, numbness, or facial changes, you feel like one side of your face is a little bit more droopy than the other side. Of course, if you can't move one side of your body or lose complete feeling at one side of your body, that could be a sign of a stroke, and that you should be checked out right away, including major quick vision changes, right? Like one field kind of gets cut out, should be evaluated right away.
Exactly. So again, we're hoping we can catch women before any of these things happen. And so some additional testing that we might do. So for example, let's say that your cholesterol profile is a little off, your LDL or the sticky cholesterol is a little high, your HDL is low, and you have a strong family history, for example, such as Sarah. We also now at True do the Boston Heart lipoprotein test, if you want to talk briefly about that, Sarah.
Yeah. So, I think I already alluded to it a little bit. Sometimes just the basic lipid panel that we see doesn't tell us enough information. And unfortunately, we've seen patients have progressive coronary artery disease despite having completely normal lipid profiles. So obviously there's other pieces to this puzzle, and I don't like surprises. So, and learning a little bit more about lipidology, which is the study of sort of lipids, how I like to think about it as our liver makes these big balls, right? And they're filled with cholesterol and triglycerides. And the point of these big balls, which we call lipoproteins, is to move triglycerides and energy around our body and provide different parts of our body with cell construction, right? But the problem with these balls are if they stay in the vasculature too long, or if they're the wrong size. So we talk about the really small, dense ones sort of bouncing around and getting lodged into the vasculature, or if they have different makeup on the outside of the ball that makes them super sticky, are all really important things to know about your lipoproteins. And there's only a few labs sort of in the country that will draw some of these labs. And one of them is this lab called Boston Hearts Diagnostics. And so we have the privilege of being able to send our patients labs there to get a better understanding of where they're at in terms of the cardiovascular risk from their lipoproteins.
Right. And you and I were talking today, so many women, I think, think that a statin is a dirty word, or they think if I take it for sure, I'm going to have muscle pain, which, that doesn't happen to necessarily a majority of women. But a lot of times having this Boston Heart test can really help us in terms of knowing, is that statin A really going to do the job, right? And is it really that important? And so I think it helps us make a decision.
Yeah, and so my end, obviously I talked to a lot of people about dietary changes, and a lot of people feel as though they've sort of failed, right? Like I failed because I need to go on a statin, right? I failed my nutritional plan. And that's not necessarily the case. Some of the makeup of these lipoproteins, some of it's genetic, right? And it's not anything that you did in particular that, thank God you get to take a statin, right? To change this kind of component of your the makeup of these lipoproteins to prevent this vascular disease. So we're here to help you figure that out and kind of guide you into that you feel more confident in taking one. And it isn't just, it's a certain level, let's just do it, right?
Yeah. And also, as a woman, let's say, adopts a more plant-based diet, which, Dr. Boyden, a colleague in Grand Rapids, has taught me a plant-based diet can work quicker than a statin. But that's a lot of learning and a lot of transition sometimes. And so even while you're getting a plant-based diet going, start a statin, and then over time, can you get off the medicine? Wouldn't that be great? Yeah. Another test that we often order is something called a CAC. So a CAC is a screening test. It's a quick CAT scan, low radiation, that takes a picture of the heart that looks for calcium in the blood vessels around the heart. And even myself as a menopause specialist, as an OBGYN, I'll get the CAC in terms of helping me decide, is it safe for this person to, for example, take estrogen? Do they maybe already have so much calcium in their blood vessels that they need to get cleared by cardiology before, for example, we would start a hormone medication?
Yeah, how I sort of present it to my patients is that, again, all these risk factors are just risk factors. They're not guarantees. And now we have this test that's pretty non-invasive, meaning it's just a CAT scan that looks at with quick cuts through the blood vessels of our hearts, and it gives us some of these answers. For sure, it's not no test is 100%, but it's way better than what we currently have. And I think the common trend in cardiology from what I'm reading is that everyone should probably have a CAC score, right? And that we all should sort of know where we're going. And I think it will be the trend over the next 10 years, sort of like a mammogram, that women get a periodic CAC score depending on where they're at and what's going on in their lives.
Right. I mean, I've had one 3 years ago. Knock on wood, it was 0. So I have no calcium. And so I'm due for another one in about 2 years. But again, it's just really reassuring. So, here Sarah is. She's in the office. She said, I've not had a period for 2 years. So we know she's in early menopause. We know that likely if she's going to follow in her mom's footsteps, and from her lifestyle, from her cholesterol, her blood sugar shows me she's got prediabetes. She's got high LDL, the sticky cholesterol. She has low LDL. Her CRP is a little high. And so I definitely would want her to get a CAC, especially if we're going to consider treating the hot flashes with hormone medication. I want to know her risk factors for heart disease before we start that.
Yeah, I think that's a good call. I think she needs to know, I think the strong family history is sort of enough.
Yes. So I agree. And so, what's so exciting is that we have more and more options for treating symptoms. And actually, it's pretty interesting to me how this can change maybe even the course. So if you guys would put up the picture showing the heart, the blood vessels from a really great study. So thanks, Dr. Simon, for sending me this slide tonight. This is from a study by Dr. Hodis. He's also the author of the ELITE trial. So the ELITE trial actually showed that women who take estrogen in the first 6 years of menopause maybe have a reduced risk of developing calcium in the blood vessels of the heart. So they had a reduced progression of the CAC. Dr. Hodis showed that after 6 years, women could still take estrogen without harm, but it didn't have the same benefit. So again, there's that timing window for hormone medication. So if you look at the top, you'll see a woman without hormone replacement therapy. So you see she develops a fatty streak, she develops a plaque, and then this plaque becomes unstable, and then potentially it could break loose and spread more or quickly expand and cause a heart attack. Whereas you see the women who took early estrogen in the second row, their blood vessels stayed pretty much the same along that same timeline. And where women start estrogen too late, let's say past the 10-year window of opportunity, it potentially could actually increase it or just be the same of a woman without hormones. So again, it really shows us that we don't prescribe hormones to reduce your risk of heart disease. It's not FDA approved for this, but it's certainly reassuring that it won't cause harm and it potentially could cause benefit. So I love the slide.
Yeah, I think it's really great to see the different variation. And I think something that's important to know about kind of the plaque formation is how I like to think about it. When you can see if you look at the upper row towards the two blood vessels on the right, there's a lot going on in that blood vessel wall, right? And so what happens, why people sort of die from heart attacks, women in particular, is that blood vessel wall sort of ruptures. And you got to remember, there's blood piping through that blood vessel. And anytime that there's sort of a misfire of the flow, it clots. And that's what ends up happening. And so, of course, you can see if you look at the middle row, those blood vessels look pretty calm and tame. They don't look like they're going to rupture anytime soon, unlike, the top and bottom row.
Exactly. And Anne Marie, I love that comment. Yeah, Rosie O'Donnell, who suffered a heart attack, she described these symptoms as what do you say?
Hot, exhausted, pale, pukey.
And this is exactly it. One of the most common symptoms of heart disease is nausea, which, it's just crazy. So we just can't blow these things off. Yeah. So thanks, Anne Marie, for that. I really appreciate it. And so then we think, what do we do about this? So for Sarah, she's getting a CAC, it's ordered. And so we'll see what the results are. But then it's all about the seeds as well. So the seeds, we talk a lot about at True, is the 7 essential elements of daily success. So not only can this help you feel better, but again, it can promote a heart healthy lifestyle. I know, Celia, when you first came, you were like, what is the seeds thing? And then, my sense is you've really adopted this and love it.
Yeah, I think it's a great format and a great way to sort of be reminders of all the different things that we need to do, to stay heart healthy and healthy on a variety of different levels. So I think it's such a great platform and reminders throughout the week, the day, however you want to use it, as to how to get healthy.
And we just got to go back to the basics. So all of you out there, I think Dr. Egan and I could talk about this forever, and we don't want to get too far into the weeds and lose you here. I think what we should maybe do is move into, what do we do, first of all, for intervention? We've talked about statins as medication to lower cholesterol. Would you want to talk just a brief second about weight loss, how we have the weight loss journey at True, and potential options to help treat other risk factors?
Yeah. So, I mean, we, at True Weight Journey, we're available if you didn't want to, see us as primary care, we're available to kind of talk about some of these weight risk factors. And one of the biggest ones is having obesity and looking at your blood sugars and your insulin levels and sort of seeing if we can use medications, dietary changes, lifestyle changes, particularly like the seeds, to get all those things sort of back online. I make a joke as a weight loss doctor, I actually care about weight the least, right? I really care about optimizing all these risk factors for heart health and getting, women back in thinking about themselves for at least a short period of the day, so they make sure that they're getting all the things that they need to do to get their blood vessels sort of as safe as possible.
Yeah. And again, what Sarah was going to do is put a picture of her mom up and just use that as her goal, that she has a picture of her mom smiling and just like, I want to be like that, when I'm, past how long her mom got to live. It's like, again, attaching all of these things to how do you want to be? And for example, last night at True, we had our Tuesday talk. Anna led a wonderful cooking class on Heart Healthy. So for our patients at True, in these Tuesday talks, it's, one of the topics is healthy eating. And so for our patients, everybody can make an appointment with Anna and get recipes and shopping lists and, depending on what you like to eat, what your family style is.
Dr. B, I think of making a good food choice. I've said this before. Making a good food choice is three things. One is education, right? What should I eat? Two is logistics. All right, I know what to eat, but how do I cook it? How do I get it to my house? How do I make it tasty? How do I afford it? And then lastly is ability, right? Able to make that good food choice all the time. And that's a lot of the times where optimizing our sleep, getting in good exercise, using our immediate breathing can really help us make good food choices along the way. And we really find that our seeds are so intertwined together, right? There's a reason why they're not just one, that they're all together, because we notice that one helps the other, helps the other, helps the other. So it's so important to kind of think about it as a group and figuring out ways to make sure we're checking boxes with each of them.
Exactly. Cool. So I think what we should do next is go into our 5 tips.
Oh, Dr. Real quick, Tammy Myers asked a quick question.
Sure, please.
Yeah, can an abundance of stress and anxiety cause symptoms of shortness of breath and waves of extreme fatigue? It's one of those things that it's a little bit of a chicken or an egg situation, Tammy. It's the question of, do you feel stressed and anxious because you're short of breath and tired? Or are you tired and short of breath because of your anxiety? Sometimes it's both, and they sort of feed off of each other, a lot of what we've been talking about. This is a great question to come in to talk with us about. And we can talk about, looking at your other risk factors, if there's any more testing that we need to do to see if we're not missing something for you.
So yeah, great question. And it's just a matter of teasing all those factors out.
Yep.
And I think we'll cover some of that too in these tips. So 5 tips that we want to leave you with. Number 1, be clear with your goal. I see so many women over the course of my career so far that just had accidental aging, right? They just went along taking care of everybody else, and they never really had a goal. I would ask them, how do you want to be when you're 50? How do you want to be when you're 60? And so many times I've never thought of it that way.
Yeah.
So, we have financial plans, we have plans for retirement, but I never see people talking about their goals. So, yeah.
Yeah. And I always make a joke to my patients. Your goal could be, I want to eat Oreos every day to the rest of my life until I die, right? That could be a goal. I don't know how much it correlates with living to 100, but still, it could still be a goal. And a lot of this is up to patients to kind of tease out what they want to do.
Right. Like I want to ski until I'm 80, and so my bones need to be strong. I want to be able to fit in my ski pants. So again, it's finding goals that really matter to you. So yeah. I recommend all of you have a goal. At True, we call it picture of self, but have a goal.
Yeah. Dr. Bitner, is there a goal of just not going through menopause?
No, everybody goes through menopause.
Oh, okay. Shoot. All right.
Sorry. Good thinking. So number 2, know your family history.
Yeah, for sure.
This is something that I think we take for granted if that's something you just normally do, but a lot of families don't talk about stuff. I have many patients who say, I was told, grandma passed, but I don't know what she died of. Or, I think there was just a time where people felt like their illnesses were like their fault, or whatever the reason is. They didn't necessarily share. And I've had many people who say they're filling out our forms for True before they, as they're becoming a new patient, they're like, it really made me think about this. Like, who's had cancer, who's had heart disease, who's had diabetes. It really makes a difference.
Yeah. And we worry about, early onset heart attacks. So that's anyone, particularly who's had a heart attack before the age of 60, particularly women before the age of 50, right? Really knowing these things and making sure that we're looking for some of those other genetic factors that would put you at high risk for vascular disease.
Yeah, perfect. So, number 3, please know the risk factors and know your lab values. I think every woman should know her cholesterol levels, and perhaps her lipoprotein with Boston Heart. She should know her sugar levels. And I can't tell you how many patients have a normal fasting blood sugar and their A1C shows prediabetes.
Yeah.
So, I really believe that you deserve to know your average blood sugar over 3 months. Now, I've gone to the next level. I talk about this. I've got my CGM on my arm, the continuous glucose monitor. It's maybe, potentially a little extreme, but it's taught me so much about my sugar levels in response to certain foods. And it's made me really look at my graph and keep track of my food choices. But you've got to know your risk factors and then know your lab values.
Yeah. And of course, like I said, we don't like surprises. So we're happy to dig as deep as we can into labs if, even if there's a lab that we don't currently offer, which I would be surprised if there was, but even if there was one, we'd be happy to look into it for you.
Perfect. And number 4 is to track your seeds. So in our app at True, you can track the 7 essential elements of daily success. I don't know about you, but if I don't keep track of my spending, I might be a little short at the end of a month. If I don't track my food, I use my Fitness Pal for my macros. I now use my continuous glucose monitor for my sugar. I think it's really critical to track this stuff.
Yeah. I think our life is just not set up for us to exercise, drink water, move, pause, eat healthy foods. You got to spend some time of bringing your focus back to those things. And I think seeds is a great way to do that.
Cool. And tip number 5, no worrisome symptoms. I know we've talked about this already, but please know what they are. Please spread the word. And it's okay to ask for help.
And do not shovel them under the carpet.
Perfect. Yes. And so we always then like to talk about 5 things we want you to ask your healthcare provider. So if you're not in West Michigan and you can't see us, these are questions I would want you to be able to ask your healthcare provider and make sure that you get an answer. Number 1, what is my phase of ovarian function? So are you in reproductive phase? Are you in perimenopause? Are you in menopause? And we know that women within 5 years after menopause, that last menstrual period, we know that their risk of heart disease can be even greater than that of a man. So it's super important to know where you are. Some women have menopause early because of breast cancer and chemotherapy. Some women have menopause early because of just their ovary gave out. We call that premature ovarian insufficiency. So there's all different reasons. Some women are, their bodies are lucky and they have super ovaries and they have menopause at 59. So super important.
Yeah, absolutely.
Number 2, have you calculated my risk for heart disease?
Yeah, I mean, I think even using the standard labs, right? Everyone can kind of be plugged into the risk calculator and they should sort of know where they are, at least on some of the standard calculators, such as the Reynolds score.
Yeah. And, we use at True, we use Epic. A lot of physicians now or providers use Epic. All you have to do is do .ASCVD and it automatically pulls in all the data and gives a risk score. So it's super easy to have that calculated. It's a nice automatic feature. So at least it starts to give us that. So again, if you're out there and you're seeing another healthcare provider other than us, make sure that you know your score. Question number 3, I want you to ask the question, how does my family history impact my risk?
Yeah, and I think we talked a lot about this already of just sort of understanding the genetics behind vascular disease and some of these other compounding risk factors that are ongoing. And so it's just so important to have that conversation with your primary care doctor.
Perfect. And question number 4, is to ask, what is my A1C?
Yeah, it's really interesting. I think slowly other primary care doctors are coming around at least to drawing an A1C, even for people who don't necessarily have impaired fasting glucose or a high glucose on just their regular labs. But I think it's always helpful to go that one step further to see what your average blood sugars are. And I think, so we love our CGMs or our continuous glucometers here at True. But I think one of the things that's super interesting is you can have periods of time when you go up and then you're kind of normal, right? Or go up with certain foods. So you're maybe not high all the time. But I think that understanding where you are on average can be really helpful to better understand where your risk is throughout the day versus just one snapshot of time, with a quick blood draw after being fasted.
Totally agree. And number 5, what additional testing can I have to tell me my risk? So again, to me, this is where that CAC falls in. But this is a question, again, your primary care doc, your healthcare provider is going to be able to look at everything all about you and answer this question. So you deserve an answer to this question.
Yeah, again, this is sort of coming close to more of a standard of care, and a lot of other doctors are getting it, and it seems to be easy accessible, in some, at least in moderate sized cities. So I don't think it's that outrageous of a question. I think that you at least should have an answer as to, where you would fall and when you would want to get this test done if you want it.
Right. And what we have found in our area is that insurances don't tend to cover this test for screening purposes. And so, we will tell our patients often there's a charge that's cash. In our area, I know with Priority Health Insurance, for example, you can go on and look at how much things cost before you have the test done. This test in our area is an average of $250 to have it done, which is cash out of pocket. What we hope is that over time, insurance will cover this actually for screening if they can see that it actually changes management and people get healthier.
I can't say, in my time, I don't, there's been so many management changes that I think I've made in the short time that it's been out, and I've been really focusing on them. So I would be really surprised if it doesn't sort of be something that becomes more of a standard of care.
Perfect. And, if anybody has any other questions real quick, I'm watching the chat. And again, Lisa and Jan, thank you so much for your comments. We love this. And I left traditional OBGYN practice so I could focus more on prevention. Dr. Egan just loves prevention. We're so much on the same page with this. Any last comments, Dr. Egan, before we go?
No, that we're really excited to talk about this. There's no stupid question. So honestly, we can talk for hours and hours about this with our patients. And as we said, we don't want surprises for anyone. So please come out and get your risk factors evaluated.
Thank you. And check us out at truewomenshealth.com. We've got lots of content to check out on social. We do as well, with lots of links. We just want to reach as many women as possible. So please share this episode if you think it could even help one person or one friend, or they'll share this and help one other person. It's Go Red Month. It's, we're celebrating that we know so much more about heart disease. We're celebrating the knowledge that we can actually prevent heart attacks. So I just get shivers thinking about this. So please share this. We want as many women as possible to get this information.
All right. Well, thanks for being such a passionate gynecologist, Dr. B.
Well, my pleasure. And thank you for being such a focus on preventative care as an internist. So thank you, everyone. Please stay safe and take care.
All right. Thanks.